Kurosaki, Senior Associate with the California Institute for Behavioral Health Solutions, and I will be moderating today's webinar. This webinar is one of a two-part series, and today we will be discussing who makes up the juvenile justice population in California and what are the pathways into the juvenile justice system. Statistical data will be presented on juvenile justice youth demographics, types of offenses, mental health diagnoses, substance use challenges, family histories, and the impact of certain school discipline policies. The goals of today's webinar are to raise awareness of the behavioral health needs of juvenile justice youth and the differential impact of certain school discipline policies on racial and ethnic minority youth, and to engage participants in an interactive and solution-focused discussion around how to divert more youth into treatment through process improvement. I am pleased to be joined by my colleagues, Ms. Sharon Wright, who will be co-moderating with me, and Ms. Kelly Vitz, who will be providing technical support. Good morning to both of you.
Good morning.
Good morning.
At this time, I would also like to say hello to our presenter, Dr. William Arroyo, who is joining us from his office in Los Angeles. Good morning and welcome to you as well, Dr. Arroyo.
Thank you very much. Good morning to you.
And thank you to all of you for participating in today's webinar. Let me just quickly review our agenda. First, we will begin with a short pre-test, followed by Dr. Arroyo's presentation and question and answer session, and then we will end with a short post-test. So at this time, let's just move right into that pre-test, which consists of 3 questions. Let's see, Kelly is going to post the first question, so you will see the question appear on your screen momentarily, and when you do, please just use your mouse and keyboard to type in your response. Thank you, Kelly. You should all see the first question on your screen right now, and I will read it for you. Question 1, families or caregivers should be partners in treatment decisions and plans. Please select either true, false, or not sure. We will give you a few seconds to do that. Okay, thank you for your response. We're going to close out that question and move on to question 2. Question 2, the blueprint model is a diversion model for youth with mental health needs in the juvenile justice system. True, false, or not sure? So it looks like about 75% of you have voted, so we're just going to hold out for about 2 more seconds here. Let all of you get your answers in. Okay, we're going to close out that question and go to our third and final question. Question 3, what are the 4 cornerstones of the blueprint model? A, collaboration, services, diversion, and treatment. B, collaboration, identification, supervision, and treatment. C, collaboration, identification, diversion, and treatment. Okay, we're going to close out that third and final question. Thank you, Kelly, and thank you to all of you for participating in that pretest. And now I'm going to turn the mic over to Sharon, who is going to introduce our presenter.
Thank you. It is a privilege to have with us today Dr. William Arroyo. Dr. Arroyo is the Medical Director of the Child, Youth, and Family Administration for the Los Angeles County Department of Mental Health and is a Clinical Assistant Professor of Psychiatry at Keck USC School of Medicine. As Medical Director, he represents LA County Department of Mental Health in program development and policy implementation efforts in the children's mental health arena at the county and state levels. His recent projects have focused on infancy, early childhood mental health, and juvenile justice. He also serves as the principal investigator of Project ABC, a federal initiative to develop a system of care for young children from birth to age 5. Dr. Arroyo actively serves as a peer reviewer for the Journal of the American Academy of Child and Adolescent Psychiatry, as a board examiner for the American Board of Psychiatry and Neurology, and has served on advisory committees for National Mental Health Technical Assistance Centers at Portland State University, Georgetown University, and the National Center for Juvenile Justice and Mental Health. And with that, at this time, it is my pleasure to turn it over to you, Dr. William Arroyo.
Have to call in today. So I have a number of slides that I want to share with all of you, which will serve as a framework for all of my comments this morning. As had been summarized earlier, these items that you see on this slide are really the elements of my presentation this morning. We're going to look at a lot of data in the first half of the slides. Then we're going to touch on what is a very sobering study for me personally that was conducted by some investigators from Northwestern University in relation to use in the juvenile justice system in the Chicago area, that's Cook County, discuss some prevalence rates of mental disorders among youth in juvenile justice systems, and then touch on the blueprint model, which was a model developed by the National Center for Mental Health and Juvenile Justice, which provides an overview of serving youth in the juvenile justice system primarily in the community. Identify some of the cornerstones, and then just share with you some information on some cost benefits of certain evidence-based practices that you might consider in your communities. And then there's a list of resources which I'll try to highlight if we have time. So with that, I'd like to move into some data published by the U.S. Department of Justice a year or so ago that relate to the those who have been held in various facilities throughout the country. What's important to note here is the decrease in youth who are in residential placement from 1997 to more recent data in 2010. And this is the most recent data that the federal government has published. As you can see, there's been a downward trend in all the number of all residents in residential placement. And by residential placement, that includes juvenile halls, camps, ranches, and that sort of thing. And then further down below, we have data with respect to the different categories of juvenile offending. The common term of status offenders refers to those youth who committed offenses, but whose offenses would not be offenses if they were of majority age or adults. They just happen to be offenses for people under the age of 18 in most jurisdictions. And then we have prison offenses, violent offenses. And you can see, by and large, there's a downward trend over those three data points. Okay. Something of special note insofar as justice issues are concerned relate to the disproportionality of youth of color who are in the juvenile justice system. So what you see on this slide are data from 2010, identifying the total numbers, the percentage, and then the percentage change from 97 to 2010. Most notably is the percentage of black youth. Black youth account for about 12% of the national population. However, they account for 41% of those who are in custody. Similarly, you might look at the Hispanic or Latino population of youth. They represent nationally 14% of the general population, but the percentage of those in custody is a higher percentage at 22, and then the others are self-evident. This is a illustration of the demographics of all children in California, so not just children in the juvenile justice population. So just to give you a sense as we begin to plow through data more specifically related to youth in the juvenile justice system. So again, this is the general population demographics, racial and ethnic distribution. The Latino population, as all of you know, comprises of just over 50%. The white population, 27%. And I just want to highlight the African American population in California is comprised of 5.5%. Okay, this I'm not going to go over in great detail because we have better data later, but these are the relative rates of detained youth by ethnic and racial groups in California. Again, this is a relative data from 97 to 2010. I want to draw your attention to the figures that we have here with respect to arrests of youth in California. This is 11 data. And as you can see, the preponderance of youth arrests is among the population of black youth in the state, and that is remarkably higher than the other groups identified here. This data relates to those youth who are actually detained. So as you may know, not all youth who are arrested remain in custody, but some do to await a hearing, and then some may remain detained even after a hearing while they may wait for some other placement. And again, these are data with respect to the different ethnic and racial groups, and the rates are per 1,000 youth. Again, the black population of youth is disproportionately detained at higher rates than the other groups. You might recall from that earlier slide when you compare the black youth population to the general population is comprised of just under 6%. However, what we see here is over 25% of the population of youth detained in California are black. These are data with respect to those who are incarcerated, so that this data reflects the number of youth, actually per 1,000, who have already had their hearing. So at hearings, many youth are released, but many youth remain incarcerated. And again, the black and Latino youth here are quite high relative to the others. This next series of data relates to that which the counties, the 58 counties, report to the State Board of State and Community Corrections Agency on a quarterly basis. And what they do is basically send their the numbers that pertain to youth that they have in their juvenile halls, camps, or in other categories, primarily ranches. The ADP stands for Average Daily Population. So as you can see from this, there are larger numbers in juvenile halls than there are in camps, but they're probably, when you add the camps and ranches together, they're probably the same as juvenile halls. Then just below that, we see the data as distributed by sex, and not surprisingly, males are detained much more frequently at much higher rates than the female population. And I think those figures are pretty self-evident. Again, this is just second quarter data. It is not annual data. And this is the most recent data that has been published by the state agency. And on this slide, what we see is the data by distribution of age, and as you can see, the preponderance of youth who are in detention facilities, again, this is a one-day snapshot, are between the age of 15 to 17. There's a very small proportion of youth who are over the age of 18, but most of the youth throughout California who are detained are between the ages of 15 and 17. In this next slide, again, we see quarter data with respect to the various counties. Now, I should say that not all counties have juvenile halls and camps, but most do. Not surprisingly, Los Angeles has the highest number of youth who are in detention facilities. The first column of figures there refers to the capacity of the facilities for detention in each one of these counties. And as what you can see here, unlike about a decade ago, most of the facilities are not filled to capacity, which is a good thing from a social justice perspective. But as you can see from this list, these are the top 10 counties who have higher census rates than the rest of the counties in the state. And not surprisingly, these tend to be the larger counties. Although, just to point out, we have Riverside that is really one of the 4 largest counties in the state, and yet they detain less than the other 3 largest counties in the state. This next slide relates to the same type of figures for counties 11 through 20. So these is the second top 10 of counties in terms of numbers of youth who are detained. And the percent of total here is the percent of all of the youth who are detained in the state. This next slide relates to the statewide capacity and average daily population of youth in juvenile halls as opposed to camps. Again, this is merely second quarter data. And as you can see, the light gray bar here relates to rated capacity, and the darker gray relates to average daily population. And as you can see from that top table, there's been a gradual decrease from 08 to 13 in terms of the numbers. So these bars reflect absolute numbers of youth who were detained in juvenile halls second quarter of 2013. And then just below that, you see the actual figures from 08 to 12. This slide reflects the distribution of charges in juvenile halls. Again, this is second quarter data from 13, and the darker gray bars on the top in the top table reflect percentage of felonies, and the light gray the percentage of misdemeanors committed by youth. And just below that, you can see the percentages relating to felony charges in juvenile halls exclusively. Now, this is similar data with respect to youth who are in camps and ranches. Again, we see a decreasing trend in the upper half, as well as in the figures in the lower table. This reflects the distribution of charges in camps. And again, they're broken up into felonies and misdemeanors, and you can see the percentage of felonies has kind of leveled off in the camps. So that has not changed very much from 08 to 13. Now, how about mental health issues? From this table, we can see the number of open mental health cases that are reported by all counties to the state again during the second quarter of 2013, and there are just under 4,000 open mental health cases. We also have data with respect to those number of youth who are receiving psychotropic medication in all of the facilities statewide during the same period, and that is just under 1,500, actually 1,453. And then we also have data with respect to number of suicide attempts in the facility statewide during the same period, of which there were 61 with no suicides reported. In the next slide, we have similar data with respect to youth who are in juvenile halls, in camps, open mental health cases, the absolute number of cases from 09 to 13. And you can see in 13 it's less than it was at the outset of this half of a decade. In this next slide, we see the figures related to the distribution of psychotropic medications prescribed to youth in halls and camps during the same period. Following that, we have data with respect to suicide attempts in juvenile halls and camps. Good news is that there have been no completed suicides. Again, this is just the second quarter of each of these 5 years. Okay, the next few slides relate to this Chicago juvenile justice study that was published in 2005 by an investigator from the University of Northwestern, and what they attempted to do here was to follow youth from the time that they were first incarcerated throughout the first 10 years afterward. And they had a sample of just over 1,800 youth. Again, there's a preponderance of males who were part of this study. Over 50% of the youth were black. And then on the right, you see a distribution of those ages of all 1,800 plus youth who were part of the study, which they followed from the point at which they were incarcerated out to the next 10 years of their life. And what they found was, which is the most striking piece of this study, was that there were 65 deaths of that population within 8.4 years. And what you see here is a distribution of the race, ethnic background of the youth, as well as their ages. And as you can see, there were 51 deaths among males and 14 among females. These were the causes of the death of those youth, and as you can see, this light purple indicates that just over 90% were due to homicide, and another 5.4% were due to legal intervention. And legal intervention, by and large, means in confrontation with public safety, police officers, and such. What we see here are the comparison between the annual deaths per 100,000, again, comparing the youth who were part of that study of 1,800, reflected in the blue bars, compared to the general population, which are reflected in the yellow bars, and by ethnic racial group and by sex. And what you can see in looking at the total figures, first of all, the really astronomical disparity between those who were detained and the general population in terms of deaths. So these are comparison among or comparing the population in the study of 1,800 versus the national general population, suggesting that youth who are incarcerated, at least in the Chicago area, have a much higher death rates than those at an early age than their counterparts in the national general population. So the conclusions of the Chicago study were that the mortality rates among delinquent youth were more than 4 times that in the general population. Among females was nearly 8 times that of the general population. More than 90% of the deaths were due to homicides from gunshot wounds. They cited an Australian study in which young offenders who died due to overdose, which is what the OD stands for, were rather high compared to only 3 deaths in the sample. And in the Chicago study, 97% youth who died of homicide sold drugs. 20% of the U.S. youth deaths ages 15 to 24 are firearm related, while in this Chicago study, greater than 90% of the deaths were from firearms. Some data on the prevalence of mental disorders among youth in the juvenile justice system. This was a study conducted by the National Center of Mental Health and Juvenile Justice. They sampled 400 youth from 29 sites, including community-based programs, juvenile halls, camps, and other residential type settings, and did a very elegant study in that they used standardized instruments to make diagnoses, and what they found were what you see in this particular slide. They found that 43% of the population that they studied had 4 or more mental disorders, and then you'll see decreasingly the yellow bar reflects 3 mental disorders, the red bar 2, and the blue 1. And overall, 70% of youth who were part of this study had at least 1 mental disorder. And then they broke down the mental disorders into the major DSM diagnostic categories in this particular slide, and separating the rates among males from females. And as you can see on the left side of this bar graph, insofar as any disorder is concerned, the female population had a higher prevalence rate as compared to the male population. And then if you go to each one of the major categories, we can also note that the female population has a higher rate in each one of these major diagnostic categories. And then I just wanted to hone in a little bit on trauma in this population, particularly post-traumatic stress disorder. And what we have here, each one of these bars represents a different study. The Kaufman and Steiner studies were conducted on youth who at that time were in CYA, or the California Youth Authority, now known as the Division of Juvenile Justice, the CDCR. The other three studies relate to populations in county facilities. But the main point of this is that what we see here is that the female population has approximately 50% of them have PTSD, whereas the male population, it runs around 30%. So again, we have female population who has higher rates of a specific mental disorder than the male population. Risk factors for mental disorders. This is kind of a lengthy laundry list, but these are risk factors that have been identified in various studies. I think those of you who work with the juvenile justice population are probably familiar with the prevalence of these risk factors in the population with which you work. It continues on to this second slide. And some of these probably are intuitive to you. Maybe the one that may be less so here is brain trauma. But what has recently been found in a study in New York City was that youth who were incarcerated had high rates of brain trauma. As to how they sustained these episodes of brain trauma is unclear. One might speculate that a number of these youth were subjected to severe physical abuse in their during infancy and early ages. The blueprint for a comprehensive model, as I indicated before, was a framework developed by the National Center on Mental Health and Juvenile Justice. And this is a framework that has been promulgated across the country to those jurisdictions that are responsible for providing services to youth in the juvenile justice system. This strongly encourages the placement of youth in communities, particularly those youth who have mental health problems. The underpinning principle being that the community is a better place to provide care for youth who have mental health problems than is a juvenile hall, a camp, or some other site where youth might be confined. So the basic principles are that a youth should be treated in the community if there are no public safety concerns. If there are, then if a youth is incarcerated, evidence-based interventions should be used. Mental health screens should be administered for every youth that enters the juvenile justice system prior to a hearing. The screen should be responsive to gender, ethnicity, race, age, sexual orientation, socioeconomic status, and faith. And screens should be provided in a developmental context. So youth are not adults, kind of thing. Families and caregivers should virtually always be partners in treatment decisions and plans. Multiple systems often bear responsibility, and so all the systems should be involved in planning. Those services and strategies used should be routinely evaluated for their effectiveness and outcomes. Cornerstones of the blueprint model are the following. Collaboration. Because youth have needs across systems, all systems must collaborate in order to attain their maximum effectiveness. There should be a task force in jurisdictions which helps organize the key stakeholders in those communities. There should be a leader. Goals and objectives should be identified. Strategic plans should be developed, and there should always be political support in order to sustain any of these strategic plans. And then, of course, there needs to be financing to support any strategic plan. Youth with mental disorders should be identified through screening for emergent needs, for routine needs. Screening instruments should have good psychometric properties, standardized, and should be completed by qualified personnel. Risk assessments are really important insofar as public safety issues are concerned and can be administered concurrently. Youth should be diverted to the degree possible to communities unless there's a public safety risk. As I mentioned before, there are many ways by which diversion can be achieved through such things as mental health courts, drug courts, of which there are increasing numbers of in communities. And there are a number of key decision-making points where diversion can take place. Intensive supervision plus treatment is often a better alternative to secure facilities, and treatment resources should be available in communities to which youth are diverted. This is merely an illustration of the various intervention points at which diversion to communities should be considered for youth who enter the juvenile justice system. Treatment should be provided largely in communities, but if youth have to stay in secure facilities, then they are strongly encouraged to be of an evidence-based type. This is a short list of evidence-based treatments, most of which you are probably familiar with, and then a few other examples. And this short list are practices that are really available in many counties throughout the state and have emerged as more popular strategies more recently. Family involvement is critical, and of course there's a difference between boys and girls, and so there should be gender-specific services. Our juvenile justice system was designed primarily to serve boys, so that we have to pay special attention to the needs of girls. And then, of course, co-occurring should go without mentioning, but many youth in the juvenile justice system have both a mental and substance use problem. This is some data that I'm not going to spend much time on, but this data reflects a cost-benefit analysis done in the state of Washington of various evidence-based practices which are identified on the left-hand side. FFT is family-focused treatment. Then we have ART, aggressive replacement therapy. MTFC is multi-dimensional treatment, foster care. MST, multi-systemic treatment, and so forth. MST again here, JO stands for juvenile offenders of substance use juvenile offender. And again, there is a cost-benefit analysis which is good for sharing with the decision makers in your communities. And then last of all, there are a number of resources here that you might want to use in your local planning efforts. There were two I wanted to highlight here, and that would be the, let me see, the one on the second resource list at the top, mentally ill juveniles in local custody. A group of folks from California developed this, and there may be some greater relevance for your communities in that document. But these, all of these are good resource documents. So with that, I will end my presentation.
Thank you very much, Dr. Arroyo, for all that information. It was a lot to digest. We have a couple of questions, and so
okay.
I'm going to go ahead and read those to you. You know, earlier in your presentation, you had a couple of slides. One was about youth arrests in California, 2011 data.
Yeah.
And then youth detained in California, 2011. And I think in both of those, they were bar graphs. Both of those had a all youth of color, but there wasn't a bar there. So one of our questions that we received from Emily was, is that information available?
Is this information available? Okay, let me see if I can quickly find that.
It's pretty early in your presentation.
Okay. Oh, by county, maybe?
I think it was youth. It's titled Youth Arrests. See, I keep going back. Youth Arrests in California. One more. Yeah.
Okay. Okay. So youth arrests in California, they are broken down here by ethnic, racial group, but let me tell you what is an even better source than this slide, because this slide isn't very dynamic. You might want to go to the website of the Burns Institute, burnsinstitute.org, B-U-R-N-S. And on the website, you will find a U.S. map, and you can place your pointer on any state, and it will give you data with distributions by ethnic and race and sex, as well as offense. It's wonderful data, and you can readily make slides from that. So please use that website as another resource for data that speaks to disproportionality of youth in the juvenile justice system.
Great, thank you. And we thank Emily for her question. We had another question come in. This is from Erica. How is treatment different with boys and girls?
Great question. And there is, you know, and I hope I included something in my list of resources related to gender-specific services, but how is treatment different? Again, we have higher prevalence rates of mental disorders among the female population, as I indicated in a few slides. And what I would urge folks to pay more close attention to among the female population is are signs of psychological trauma, because again, as I indicated on one of my slides, it appears that just over 50% of female youth in the juvenile justice system have PTSD. And the nature of the psychological trauma tends to be different from that of the male population, so that many of the female youth have been sexually assaulted in some way. And so special attention needs to be paid to that. Furthermore, there may be some relationships that speak to what might be a more ideal, what might be the ideal sex of the therapist working with that female. Let's say in the case of a female who has been repeatedly sexually assaulted by a male, it may well be very difficult for that female to work with a male. And so that needs to come into consideration. And it may also speak to the kind of personnel or staffing that one might have in a secure facility or even in a more general treatment setting, if you have a female who might have been traumatized at the hands of a male perpetrator. So that's the kind of thing that one needs to pay attention to. And there are a number of publications that also speak to female general needs in secure facilities. So that, for example, the bathroom setup for males really is not ideal for females. Females just have different grooming practices, for example, and so that the setting in which a female youth is placed, particularly in a secure setting, should really be markedly different from males. So that's the kind of thing that one needs to pay attention to.
Thank you, and we thank Erica for her question. We have, Dr. Arroyo, we have, it looks like we might have another question and a comment coming through, but we're pretty much at the end of our time. So you know what, I'm just going to ask that we'll share this with you and see if you can give a written response that we can email to these folks afterwards.
Okay.
Great. Well, thank you again. And for all of you who are participating in the audience today, I just want to let you know that this was part one of part two, and there are two parts, so that I welcome you to come back. We'll be having another webinar in February, and we will be covering some other issues, including addressing some of these treatment questions. At this time, I'd like to take a look at those questions again. This is going to be our post-test, and we'll see how much we've learned. So Kelly is going to bring those questions up for us. All right, so you should be seeing question 1 again, and that is families or caregivers should be partners in treatment decisions and plans. True, false, or not sure? Great. We're fast answering these questions. We learned a lot. Okay, so the answer is true. Kelly's going to put up question 2. Thank you, Kelly. The blueprint model is a diversion model for youth with mental health needs in the juvenile justice system. True, false, or not sure? Okay, so the answer is false. Although I know a lot of you answered true, diversion is part of it, but the correct answer is that the blueprint model is a comprehensive model for the identification and treatment of youth with mental health needs in the juvenile justice system. And finally, question 3. What are the 4 cornerstones of the blueprint model? A, collaboration, services, diversion, and treatment. B, collaboration, identification, supervision, and treatment. Or C, collaboration, identification, diversion, and treatment. Thank you. So the answer to that is C, collaboration, identification, diversion, and treatment. So thank you again for all of you who participated in the post-test. Once again, I'd like to thank Dr. Arroyo and thank all of you for participating in today's webinar. Just a reminder, there's a brief survey at the end of the session as you exit the GoToWebinar, and it's to let us know what you liked and what you didn't like about today's webinar. So I'd encourage you to take a few moments to share your feedback. And we do look at them and read them and use them to make improvements for our work. So thank you very much in advance for taking that time. With that, again, we're at the end of our time, so we're going to conclude our broadcast. We thank you again for joining us and wish you a wonderful day.
Okay. Thank you.